Welcome everybody to our webinar in the CAN AMS series today. Good morning or good afternoon for wherever you are located today. Welcoming you all and to our event called Drop the Label, Penicillin Allergy Delabeling is for Everyone. I'll soon welcome our moderator, and our speakers are at the ready, but just wanted to make you aware that the CAN AMS webinar series is co-hosted by National Collaborating Center for Infectious Diseases and the Association of Medical Microbiology and Infectious Diseases Canada. I'm Harpa Eastfeld-Keeley, and I'm a Senior Project Manager with the NCCID. Before we get started today, I would first like to acknowledge that the NCCID is hosted at the University of Manitoba, which is situated on the ancestral lands of the Anishinaabe, Anishinaabe, Dakota, Dene, Nehethawak, and Innuit nations. It is also in the heart of the Métis Nation. At NCCID, we strive to honor the lands and their original caretakers in our work, and we are committed to working with our partners toward reconciliation. We would also like to acknowledge the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, we would like to take a moment to acknowledge the importance of the land which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. I just have a few points of housekeeping. Attendees are all on mute and the chat box is disabled. However, we look for your questions in the Q&A box. Upvoting is active, so you can check out what other questions are coming in and upvote. Today's recording will be posted on the website amraware.ca, the webinars page. It'll also be posted on YouTube at NCCID's account called Center Infection. You'll see there's a playlist there called CAN AMS Antimicrobial Stewardship Webinars. That's a playlist. So if you're having any technical difficulties today, please email Crystal at ami.ca is her website, email address. So this event today is part of a series you may know. You might want to check back to look at other events, past events. We have the recordings posted, as I mentioned. So the series is co-hosted by AMI and NCCID, and the people behind it are part of a network we call AMR Aware Canada, and a website. The website reflects resources and an annual campaign that raises awareness for AMR in Canada. And leaders from all across Canada are sharing knowledge of antimicrobial stewardship interventions, and a working group goes into planning these events. Just to flash this in front of you, gain some recognition of the AMR Aware Canada and network and the campaign by the same name. So we have a campaign every World Antimicrobial Awareness Week in November, and we're developing more ongoing work like this CAN AMS series, resources, and other work. So now I'll ask Nick Smith with the Community Antimicrobial Stewardship Program, BC Centre for Disease Control, our moderator today, to take the mic. Thanks, Nick.
Thanks, Harpa, and thanks everyone for joining us here today. As Harpa said, I'm Nick Smith. I'm a project manager at the BC Centre for Disease Control, where I work with the Community Antimicrobial Stewardship Program. I'm grateful today to be joining from the traditional ancestral and unceded territories of the Coast Salish peoples, including Musqueam, Squamish, and Tsleil-Waututh. I'm happy to be moderating today's session on penicillin allergy delabeling, which is such an important tool in the toolkit of antimicrobial stewardship. We have three great speakers joining us today who will be providing insights and expertise on this topic. Tiffany Wong is a pediatric allergist with BC Children's Hospital and a clinical associate professor at the University of British Columbia. Chelsea Elwood is an obstetrician with BC Women's Hospital and a clinical associate professor at the University of British Columbia. And Haneen Albayadi is the spread quality improvement lead at the Provincial Health Services Authority. And together they'll be talking about some of their work in penicillin allergy delabeling, and we're really excited to hear about that. Next slide, Harpa. There's a few learning objectives for today's webinar, so we hope that all of our participants by the end of the session will be aware of the role that penicillin allergy delabeling plays in stewardship efforts, understand steps to and challenges in helping patients achieve accurate penicillin allergy labels, and learn about tools and resources that can aid practitioners in assessing penicillin allergy labels in their patients. Next slide. And just before I turn it over to Tiffany for our first talk, we want to poll the group with just one question. So you should see a pop-up appearing at this point in time, and we just ask you to answer the question: how comfortable are you challenging and removing a patient's penicillin allergy label? And just give a second for you to lock in your vote. Okay. And here we're seeing the the answers to the poll. If you click on the poll button, you should be able to see how people have answered. We're seeing that the most 36% of participants are saying they're somewhat comfortable in challenging removing the patient's allergy label, but some that are somewhat and very uncomfortable as well. Great. We'll revisit that towards the end of the presentation, but for now, I am happy to turn it over to our first speaker, Dr. Tiffany Wong. Tiffany, take that.
Thank you, Nick. Sorry. There we go. Okay. Welcome, everybody. Thank you so much for joining us. It's morning here. I'm also presenting from the land of the Musqueam, Squamish, and Tsleil-Waututh Nations. This is Vancouver. It's a gorgeous day out, and I'm very grateful to have people joining from all over Canada and start our week off in a good way. These are my disclosures. So today we hope that we can get everybody a bit more comfortable with delabeling penicillin allergies. I brought two colleagues along with me who are leading this work in very different but very important ways. And now you have three perspectives instead of one. I will start with some background because I think it's important to get everybody on the same page and give a little bit of history about how we got to where we are today. So penicillin allergies are common. I think probably most people on this webinar will know that. About 10% of the North American population reports a penicillin allergy, but at least 90% and up to about 96% of children are not truly allergic when they're assessed. And this is important because most children or most people are diagnosed with an allergy by the time they're about 3 years of age. The most common reasons for mislabeling penicillin allergies are really in the realm of miscategorized symptoms. So most people, the story is that they got sick with an infection, they got antibiotics, and then they got a rash. That's the most common story. But we know that typically these rashes are related to illness. Sometimes people misattribute side effects of medications to being an allergic cause. And then there are a group of people who have this idea that allergies are inherited, which some are, but drug allergies are not atopic conditions. So we don't pass those on. Having said that, a lot of people worry that if their mom was allergic, that they're also allergic. And things like fear and anxiety can perpetuate concerns regarding allergy. So it's widely known that erroneous penicillin allergy labels are a public health problem. It leads to poorer care for our patients. We're using more antibiotics, less grade antibiotics, more broad spectrum antibiotics. And this can all lead to poorer outcomes. So longer duration of treatment, more bounce backs to hospital stay, adverse effects. And of course, there's a wealth of data indicating that there's increased cost to the system. So what is penicillin allergy delabeling? This came about, it started in the United States with the Obama administration. And how this really came to be was that we had multidisciplinary antimicrobial stewardship programs, generally located in hospitals, where they would proactively identify people who identified penicillin allergy. And instead of waiting to see what happened or choosing alternate antibiotics, they would do a really great medical history, proceed with skin testing, and then an oral challenge if the skin testing was negative. Now, this was really evolved over time. With the onset of these programs, they also studied the efficacy of the programs. And again, it's well documented that delabeling programs were able to significantly reduce costs to the system, alternative and inappropriate broad spectrum antibiotic use, things like length of stay and mortality. Having said that, the number of people who think they have a penicillin allergy far outstrips these specialized programs. And so what I have set out to do in the last 10 years was to help people who don't necessarily have special teams, or even if you have the special team, that's great. But penicillin allergy delabeling is not hard if you can understand the basics of drug allergy. And so when we talk about penicillin allergy, most people are really concerned about the type 1 or immediate drug allergy. So this happens with the symptoms happen within 1 to 2 hours max of receiving the medication. And we're looking for signs and symptoms including hives, cough, wheeze, trouble breathing, vomiting, diarrhea, hypotension, and any combination of this can be anaphylaxis. So this happens very quickly and also has fast offset when the medication is removed within 24 hours. We do have non-immediate drug allergies. So these are the type 2, 3, and 4. And these tend to be quite serious. We're looking for signs of systemic illness like fever, arthritis, vasculitis type symptoms. And then we have type 4, which is very scary to a lot of people, severe cutaneous adverse drug reactions like Stevens-Johnson syndrome and Druss syndrome. Remember that severe reactions are very rare. Anaphylaxis after IV administration is just about 1 to 2 per 10,000 treated patients, and this has fallen over time. We do have testing available. I wanted to tell you a bit about the limitations of our skin testing. So we can do it. It's only useful if you have a history consistent with a IgE or immediate drug allergy. So this isn't for any delayed drug allergies. We would do a skin prick test followed by an intradermal test, which goes a little bit deeper into the skin to see if we can elicit an allergic reaction and get a hive. So on this slide, this person has positive skin testing. So you have the bump and redness around it. The negative predictive value and the sensitivity is very good. Having said that, it is a very poor screening tool. So if we're using it just to see if someone has an allergy without any clear history, it's a pretty poor test with a positive predictive value of only 50%. And this is why we don't use it as a screening tool. Some countries still do, but it really shouldn't be. There is a blood test for anyone who's wondering. We are also, again, looking for specific IgE to penicillin using an ELISA assay. And again, it's not great. So the specificity is high, but because we get a lot of false positives, it's a poor screening test. Sensitivity is also not great because what happens is over time, as the years go by, the actual IgE level of the antibody decreases. And after about 3 to 4 years, it's really, you're probably going to get a bunch of false negatives as well. So with skin testing and blood testing not really being very useful, what we're left with is taking a really good medical history and identifying risk based on the history itself. And this is the part I think that everybody gets a little bit nervous about. But if you look at the different types of drug allergy, if you interrogate the label really well, you can get a really good sense of what happened and the timing and the symptoms just by asking questions. And this only takes a few minutes. And remember, most patients aren't actually allergic. I think that's what we all have to remember, is that most people aren't allergic, over 90%. And so the only true gold standard of test in penicillin allergy assessment is the oral challenge, so giving somebody penicillin. Assessing risk comes down to, again, a few questions, and you can see on the spectrum here, patients with anaphylaxis or delayed reactions looking like systemic severe cutaneous adverse reactions or requiring a hospital admission, those are high risk. And for these patients, is generally recommended to avoid, pick an alternative, and refer to an allergist. For the lower risk patients with a delayed mild rash or only a family member who is suspected to have an allergy, most of these patients can be delabeled in any office setting and even with a test dose, even the community, even a rural setting. So what about delayed rashes? If this is most of our patients, mild rashes, especially the delayed ones, are not associated with any increased risk of anaphylaxis. Most of these are infectious. About 5% of these patients will develop a recurrent delayed mild rash with antibiotic administration. But even with our current international drug allergy guidelines, we don't consider them a contraindication to future use because they are mild delayed rashes. If you see this type of rash in your patient, mucocutaneous involvement, target lesions, or generalized pustulosis, and some systemic symptoms, that this is when you worry about delayed severe drug reactions, and you should definitely avoid. All right, so there are a multitude of guidelines and toolkits published in the literature. You'll see a couple examples here. There are many. We have even come up with one ourselves about 10 years ago, and that's been validated. Having said that, I know that most people don't have time to go digging into articles and run through these complicated algorithms when you're mostly seeing these patients for something else. So what we did was develop, along with Firstline, a point of care decision support tool. So we took our validated algorithm, tested it electronically many times, and made it into an app, into a tool that's available on the Firstline app. It's also freely available online without the app for those of you who don't work in centers that have Firstline. And so there's the QR code there. All right, and so the tool will lead you through the questions, and answers can be entered in real time. And you'll be prompted to ask about timing, symptoms associated with the suspected reaction. And at the end of it, again, it only takes about 5 minutes. You will have a prompt come up to indicate the risk of penicillin allergy and a recommendation for what to do next. I will acknowledge that there are other point of care risk assessment tools that are available online. PenFast is one that's very popular. It is a quick and dirty tool. It's even faster than ours. I will say that there are some limitations to this because there are slightly less details, and personally working in an academic center, this I think is a bit harder to teach our trainees and the people we work with to think about what the actual symptoms might have been. But there are many centers who use this, and Dr. Elwood's team does as well. Then the next thing people are really worried about is actually conducting an oral challenge. So we now have data from all populations, pediatric, pregnant women, general adults, indicating that in carefully selected patients who are identified to have low risk, a direct oral challenge without skin testing is safe and effective. And you can do this in one dose. You do not need a graded challenge. What does a drug challenge look like? We take consent, we do a quick physical examination, if possible, to check for rashes, especially in peds, it's important. If there's a rash before the medication is given, it doesn't count as a adverse effect. We give a dose, single dose. We do this across BC all at once. In other provinces, they do still do graded challenges, but we don't. And then we observe for 30 to 60 minutes in a waiting room or nearby. When the drug challenge is complete, as long as the patient has passed, we like to give documentation. And this document is meant to be taken to the community pharmacy because our EMRs are often not connected. And then on our end, we will remove the label from all of our hospital records and our provincial records if possible. And that closes my end of the presentation. Now we're going to move on to Dr. Elwood. And now this part of the presentation is going to be about the logistics and actually doing the work within a practice setting. All right, I will stop my share now.
Hey, Tiffany, give me 2 seconds and I will share. I'm sure someone can stop me if they can't see, but we'll get started. So I am an obstetrician. He's trained in infectious disease and connected with Dr. Wong and the allergist in BC fairly early. And we kind of sat down and thought to ourselves that this data seems very good. And there's a very clear application in obstetric population. And if we can do it in pregnant people, there's very few populations you can't do this in, because this is a fairly vulnerable population where we're both taking into account the pregnant person's health and the risk of anaphylaxis in them, but also the potential significant impact of anaphylaxis in the fetus as well. For me personally, my research is supported by a bunch of funding agencies, maybe not NIH anymore, but hey, what can we do? I give talks, but mostly it's around stuff like don't do that because they're pregnant, or do that because they're pregnant, and that everything we sort of recommend in pregnancy is off label, but that's normal basically for everything in pregnancy. So what we were trying to do was take this knowledge around the validity of allergy testing and the fact that most of those allergies are not correct, and offer systematic access to penicillin and amoxicillin allergy testing services, first at BC Women's Hospital, so PHSA, and then at expanded sites, including Vancouver Coastal. And in the province of BC, which is where I generally work, we have multiple health authorities, but we would start small, smart with a small clinic, and then move and expand to other spots in the province of BC and support those kind of things. And along those lines, I work in the same place as Tiffany does in terms of the ancestral territories we work in, but we really do serve all of the Indigenous peoples in BC when required. So why do we care specifically in pregnancy? So everybody knows we care in general, and we care because of broad spectrum antibiotic exposure and all those kind of things. But why do we specifically care in pregnancy? There's some good data that shows that those individuals who present to labor and delivery with a penicillin allergy have higher rates of cesarean section in GBS positive individuals, so group B streptococcus, which colonizes the vagina of a third of pregnant people. And the #1 drug of choice for GBS prophylaxis is penicillin. They have an increased wound infection rate, and with a cesarean section rate of about 30% in most provinces in BC, not all, but most provinces in BC, that increased wound infection rate is not insignificant, and it's because of the use of alternative prophylaxis for surgical site infection. They have an increased length of stay, and then obviously increased antibiotic exposure, not only on the pregnant person's side, but also on the neonatal side. And so as I tell patients in clinic, we like to choose our first line. And in pregnancy, most of our beta lactams are our first line antibiotics of choice. And if you walk into my labor unit, like was it 3 o'clock this morning, because I was on call last night catching babies, and you tell me you're allergic to penicillin, I'm going to make an alternative decision around prescribing for you. And it's not that that alternative decision is bad, it's just not as good as my first choice. So we opened a clinic. And the structure of the clinic, if you were to do this for you, for example, is you need a registration clerk. You need a nurse to help you. We do it with a pharmacist. So our AMS pharmacist joins us. And we do it because they're pregnant. We do it with an obstetrician and an allergist sitting in the same room. And we actually do it in a post-anesthetic care unit where we have 6 beds. We line up 6 people. We go through one wave. We line up 6 more people. We go through a next wave. And we do that a couple times a month. We have supported other clinic models where there's no obstetrician present at smaller sites, but the obstetrical team is aware of the clinic and able to support if there is something that occurs, an event that occurs. So there's different ways of doing this, but this is how we set this up because this was really the first clinic to really get after this and tackle this problem. And those concerns around anaphylaxis were very real, but as I'm going to show you, less common than people think. So how we do it is we pre-screen individuals so they get a phone call. We use that first line scoring or pen-fast scoring system to risk triage individuals before they present to the clinic. So we know what we're doing and we book accordingly so we can have a high volume throughput. And then testing is either done by a direct oral challenge or skin testing, depending on the outcome of their conversation with the allergist beforehand. While they're sitting there, they get group counseling about what we've done, what this means, what the outcome is. We hand them a patient education handout that they take out in their hot little hand because I talk fast, and so it gives them that information to go home. We actually go into their provincial pharmacy database and we actually remove their label if it's present there. They get a dictated permanent consult on to their primary care provider, their maternity care provider, and the provincial medical record. And then we go into our computer-based system to be able to remove that label if it's present. And most of the sites that we've supported to do this also do a similar type pattern. So the first thing we had to do was figure out if we could offer direct oral challenge in pregnant people, just like you can in a non-pregnant individual. And this was one of our first 245 sets of individuals who came through. And we were able to show that a direct oral challenge was a safe thing to do in pregnant people. So you can do direct oral challenge. Yes, you can use a risk stratification system. No, you do not need to skin test every pregnant individual. And you can go straight to direct oral challenge, which is beneficial from a cost effectiveness, time effectiveness, patient perspective. There's lots of good reasons. And we were able to delabel about 240 of those first 245 individuals. Now, some of those were on history, a couple of them were on history, but most of them just simply received a direct oral challenge. We've continued the clinic since then in 2019, and we've sort of looked to compare ourselves to other sites out there and what else is happening out there. And this is a recent comparison with some work done in Manitoba. So there was a program in Manitoba where individuals would come in with an allergy to penicillin. They would receive their initial skin testing, and then the direct oral challenge component of the testing protocol would happen postpartum. And for those of you who do provide obstetrical care, you know how the postpartum period is. For those of you who don't, a newborn baby leads to many challenges, and getting people to come to appointments, to take medications, to do any form of testing postpartum is very challenging and very difficult. So we compared those two approaches, and we're able to show that in our one step during pregnancy approach, we were able to delabel about 97% of individuals who were referred. For those individuals who went through this 2-step approach, which is sort of driven by the concern around anaphylaxis with the direct oral challenge, about 38% of them were actually delabeled. So a significant difference with this one step. We've got you while you're pregnant. The other thing about pregnancy is that pregnant individuals are generally highly motivated, fairly engaged in care, and really keen to do things. So we book them between 28 and 36 weeks, and they come in for a 1 visit. It's about an hour-and-a-half appointment for them to be able to have everything done. The other thing that we do is we try and compare and deal with that sticky label phenomenon. So people tend to have more than one baby. It's a thing that happens. They come in, they have one, and then they decide to have another. And some people have three, or some people have four. And we wanted to make sure that there was a durability to what we were doing, because it's not helpful to delabel someone for their first baby and have their allergy reappear on their second baby. It's also not good for their life in general when they're like 50 years old. But from a pregnancy perspective, that's where we landed. And we were able to demonstrate that we were managed to continue with that label after 3 years being absent from a patient chart. Less than 4 to 5% of people had that label reappear on their chart through this method. So it's a fairly effective way of doing things. And I do think that part of it is the engagement and teaching we have with patients and the advocacy that they have. Most of the patients and individuals who come through the clinic are very comfortable with the process. They're sitting in front of an obstetrician and an allergist. We talk them through the whole thing, but they're very comfortable. I will say that that is a select group of individuals who've agreed to come to the clinic to begin with, so probably pretty motivated to start. And we certainly are not getting our most reluctant crew, because they just won't come. But certainly those individuals who felt empowered to walk out and say, you know what, I'm not allergic to penicillin. My mom told me I've been allergic for 30 years, and we're not actually allergic to penicillin. So that's been particularly helpful for individuals. We did do a health systems cost analysis, which we looked specifically at the obstetric population, and we looked at that concept of first delivery, second pregnancy, and then lifetime benefit, and showed that there is a benefit from a cost savings of about $1,500 to $2,000. And then from a lifetime cost savings, you're looking at between $58,000 and $65,000 per individual that we put through this clinic, which is helpful for funding, helpful for asking, helpful for clinic space, but also helpful for the system as a whole, because not only are you getting the direct patient benefit, but you're getting a systems benefit from it. So overall, we've just recently had a look back at our outcomes since we started in 2019, and we did close during the pandemic for about a year and a half there. We've had about 743 individuals through the clinic. We've had a 97% delabeling rate. We've saved the healthcare system about $48 million in cost savings. And really what we've shown is that you can do this in a pregnant population. We've supported some changing in guidelines, and we've supported other sites to do so in a model of care that makes sense for their site. So you do not have to have an obstetrician sitting with patients while you do testing. One of our other sites, Lionsgate Hospital on the North Shore, does this with their pharmacist and their infectious disease doc who does all the testing. And that's perfectly reasonable and perfectly fair. And we're always happy to support clinics in opening in whatever capacity you can do, because this is a safe and smart thing to do. And I'll hand it back to our next person.
Thank you, Dr. Elwood. I'll just quickly share my screen. Okay. Hi, everyone. My name is Haneen, and I will be walking you through today an initiative that we did provincially to spread the work that Dr. Wong and Dr. Chelsea presented on, and walk you through what we did to implement that. Just quickly want to mention that I am actually calling today from the Coquitlam First Nation land, which is known as Coquitlam today. It's about 30 minutes away from Vancouver downtown. So the term sprint is not unique to the work we did. The term sprint methodology is actually used in other software development and other industries, particularly where projects are actually complex and require flexibility and benefit from repetitive development and frequent feedback. So I just wanted to introduce the term sprint and let you know that it's not really unique to the work we did. Usually people go with sprints because they make the projects more manageable, they deliver high quality work and more efficiently and more frequently, adapt quickly to changes and feedback. And this is exactly what we needed for what we had for the project at that time. But why did we decide to go with the sprint methodology for specifically penicillin allergy delabeling? by the time that Dr. Wong and Elwood did their work, the word was spreading organically widely. And then formally, we took on this project as part of the Spread Quality Improvement Project and program to spread this work. But it was actually spreading rapidly to the point that it wasn't efficient anymore. Dr. Wong was getting emails, so are the allergists that are supporting her. And we got to a point, even though we were actually following a spread framework within our program, this project was spreading beyond what efficiency is anymore. Also, having our program fall into the Provincial Health Services Authority and our role as a provincial authority to actually shape the strategy on how we spread work province-wide. Also, the project scope and the outcome, it was a very specific outcome, which is removing the allergy label. Compared to other collaboratives that you probably have heard of before, where there is multiple outcomes and multiple levels to the project, this was very specific scope. So it fits the sprint methodology. And also we had expertise within our team. Even though we knew there must be something we need to do to spread this project more efficiently, we actually attended a collaborative training with the Institute of Health Improvement. And after chatting with the coaches and the IHI expertise, they actually did recommend the sprint as methodology to spread this project. And also we had funding available to support this work through our Spread Quality Improvement Project, which falls under the Medical Affairs Department at the Provincial Health Services Authority. So all the stars aligned for us to go ahead. We planned the initiative's objectives based on the situation we were dealing with the rapid spread. So we actually wanted to streamline the project spread. And also, we wanted to provide equity and access to remote communities in BC. As both Dr. Wong and Elwood mentioned, not everyone has an allergist and a team of expertise available. And having remote communities access this service with the training and capacity, we will be able to hit our objective. Also, we needed to enhance collaboration across BC sites. So many people were actually doing this work in different pockets of BC, but they were not aware of each other and they were not connected. So we actually had an opportunity to create this space of collaboration for the teams. And we also needed to pilot a new approach to scaling QI work, quality improvement provincially, as this was a very unique project that we haven't came across this, I would call a good problem before, where the project was actually spreading rapidly. So we put together a faculty that included Dr. Tiffany Wong, myself, and Dr. Rochelle Stimson, which works from BC CDC. And she was already working on this project before the launch of the sprint with a specific population. And we also had the director of our medical affairs program for engagement and initiatives, Bettina Abrahams, to support this work. I will talk into details shortly on what each period included and how we were able to achieve this, but I just wanted to present the timeline. By the time we got to February 2024, which was about a 6-month period of the initiative, we actually realized that some teams were ahead of each other because they were already doing this work before the sprint started, and some had competing priorities. So not everyone were able to achieve their objectives by February 2024. So we actually surveyed people who were participating in February 2024. Then we asked, would you be willing to extend it and come back if we gave you more time and funding? And 100% of the participants said yes. So that's why when we decided to actually modify our timeline based on the feedback, and we extended the last action period, and we concluded in October 2024 instead of February 2024. So I'm just going to walk quickly through the initiative timeline and what we did in each step, just to give you a better understanding of how we were able actually to spread this to 20+ teams at the same time in a very short period of time. And I just want to point out that the teams that were participating in were actually consisted of different type of healthcare workers. So some had a physician and a pharmacist, some had a physician and nurse, some had NPs only due to their availability in the community. So depending on the combination of the team you have, this work can be done in different type of combinations, and you don't have to have a specific set of expertise available, as long as you have the team and workflow and the training and the capacity. So we wanted the team to prepare for the launch of the sprint. So we actually sent out a kind of a prep report period about a month before we launched the sprint. We wanted people to understand their population, understand their current workflow. If someone has a penicillin allergy delabeling, how are they flagging that currently? We wanted them to do a scan of their environment and their team readiness and the training, and also see if they need any leadership support and engagement before we actually launch this sprint. Then we met again in learning, sorry, not again, we met them in learning session 1, which was virtual. And our objectives of the first learning session was actually to just walk through the project background, introduce them of the work we did. We brought in a patient story to show the impact that this can have on the patient's health journey. And we also introduced them to our program, what we do in the Spread Quality Improvement Program. We introduced the idea of a change package, which I will let you know about later. And then we gave them some time to actually go into breakout rooms and talk about the current work that they do and how they can support each other. And then we had an action period of about 3 months where people went back and we sent them with a template for a storyboard that has different components that they needed to work on before we come back again in person. And the storyboard actually served as a template to drive the work. So it's not only for reporting, but it's actually meant for them to follow the implementation plan. And also during that time, they actually had access to coaching support from our team. So we were able to help them, for example, with their current workflow, any quality improvement tools that they need, and also hosting meetings along the way just to make sure that any support that they need that was available from our team. And also that's when we launched the data and tracking sheet, because we cannot know if there is an improvement or how many people are being delabeled if we don't track that. Then we met in learning session 2, which was in person in November 2023, and that was a huge success. What we were able to do is have some teams present on the work they did. They presented their storyboards. They were able to chat with their colleagues, share the learnings, and share the also challenges. And also we provided people with some directed, self-directed work so that they can actually move on to the next step before we wrap up. And I also included some of the survey feedback of how well they think this initiative is running. And we also collected evaluation at each learning session because we wanted to respond to the feedback from the participants and also cater our support based on their needs. Then moved on to action period 2, which was right after the second learning session. And that's when we actually refined the change package. And that's when we started having the delabeling numbers go up. And the change package is actually available on Drop the Label website. And what it is, it's a combination of steps and change ideas that would allow your team to kind of, it is meant for a guide. If your team is not sure where to start, if you're interested in actually implementing allergy delabeling in your clinic, this serves as a guide on how to start. So it has background of the project, some resources and tools and examples on what we use here in BC that might help your team to implement the project. And this is a working document. So when we get anything new or any updated information, we will update that. So by February 2024, by the time that the initial timeline where we needed to close the initiative, we actually had 19 teams participating, in total 71 participants. And this is a map across BC that shows where the sites were. So we were actually spread out all over BC, some sites including in the north, on the island, and also Lower Mainland. We concluded with the virtual session where everyone came on with an action. And we also had a guest speaker from the Institute of Health Improvement just to push us and learn about sustainability and how we can actually sustain this work after we wrap up the initiative. And then that's when we surveyed people and asked them if they want to come back, and they said yes. And that's when we did in October of 2024, when we had an in-person session. And it was most of the objectives of that session was mostly to just share and celebrate the work that we've done. This is actually just a chart that shows the percentage of patients that are delabeled from total patients assessed. And it looks like we were actually reaching a very, very a high number where we wanted it to be. And you see the fluctuations, and sometimes that depends on like the implementation period and people pivoting. Also, this was the group photo that we had, and I wanted to give also a snapshot of the feedback, because we had an overwhelming positive feedback with people who participated, and it was reassuring that the work we did is needed, and people actually needed that work. By the end of session on October 2024, we had over 800 people assessed, and out of these people, 600 got delabeled. It is not at the 98% that Dr. Elwood and Wong mentioned. It's just because it included some implementation processes. Also, some people were contacted and haven't been called back and so on. So that's the difference in the percentage, but we had over 600 people delabeled. Those are the initiative key outcomes. We actually were able to develop a change package that I mentioned, which is available on Drop the Label website. We increased the confidence among providers and allied health professionals in performing penicillin allergy labeling procedures. We also created an EMR guide for power forms and other data collection resources. As mentioned earlier, our EMRs are not always connected, so we wanted to make sure we have some guidelines and power forms to help people maybe automate the data so it's not manual collection. We standardized some of the oral challenges protocols by modifying based on the feedback that we received from the participants. We developed patient resources and informational pamphlets that you can find on Drop the Label website. We also launched the patient assessment tool, and we created an EMR guide, as mentioned. Where are we now? We are navigating the further spread of this project because it keeps spreading. So we are trying to hand it over to other health authorities so that they can get support locally for sustainability. We are trying to continue supporting the current teams that are maybe in between, transitioning between us and their health authorities, or they're still in their implementation process. We're connecting beyond BC. We actually recently connected with a surgeon who contacted us from Ontario, Dr. Jennifer McMillan, who saw this website, and she contacted us to hear about our change package and work, which was great. And where we want to go next, given the engagement and the success and support that we had from all participating teams, we are hoping to explore a provincial penicillin allergy network. That's still in the work. I think Dr. Tiffany Wong is actively working on the patient assessment tool, and it's a research project that will empower patients to do their own assessment. We're working on reporting and documenting key learnings, so we can hopefully publish this for people to learn, and also hopefully join us with this penicillin allergy delabeling work, and navigating ongoing interest in this work. And also, as Dr. Elwood mentioned, there was a cost-benefit analysis done on the clinic that they did. We're also trying to expand the cost-benefit analysis to more generalizing populations, so that's in the work as well. And also continuing effort to update the resources that are available for the Pen delabeling. So if you have any questions about our program and our work, this will be our contact email. Thank you so much for listening.
Great, thank you, Haneen. It's a really great presentation, and thank you again to Dr. Wong and Dr. Elwood for their presentations as well. Just before we go into the question and answers, we wanted to ask the same question. Harp, I don't know if you're going to share the slide, but Crystal, you can launch the poll as well. Yes, so now that you've heard what you've heard, we're just asking the same question again. How comfortable are you challenging removing a patient's penicillin allergy label? Again, I'll just give you 5 seconds to lock in your answer. Should see the results of that any second now. There we go. And that's the change that we were hoping to see. that we've seen a shift towards the very comfortable and somewhat comfortable compared to before the presentation. So I think that is the point that we want to drive home, is that this is a very safe and effective strategy for reducing unnecessary antibiotic prescribing, and especially alternatives to penicillin. With the few minutes we have left, I wanted to get through as many of the Q&A questions as we can. So we have some coming in. I will read them out in the order that I see them here, and any of the panelists feel free to unmute and answer as necessary. The first says, if a young child was formally tested 30 years ago, positive, allergic after a rash by a doctor or allergist at a pediatric hospital with multiple small needles plus other pinpricks, how likely are they to outgrow that allergy?
Thanks, Nick. I'll take that one. Great question. There is good data that indicates that by the time a patient is reassessed about 5 years after an initial diagnosis of penicillin allergy, 50% of them have lost enough specific IgE antibodies to have outgrown their allergy. Likely by the time 10 years have passed, about 80% of them will have lost all of their antibodies. So we recommend that if a diagnosis is made, they be reassessed every 5 years.
Great, thank you. Next up, how can community pharmacists participate in delabeling allergies?
I guess that's me as well. So, I mean, the topic of this presentation was that everyone can participate. And I do think that community pharmacists have a big role if you want to participate. So we've created the tools where we actually do have a really good text-based patient tool right on the Drop the Label page, where patients can do their own risk assessments, and you can get your answers emailed to you, and then we recommend bringing it to the family doctor. So if you could even just encourage them to think about it, that would be great, asking their physician for an assessment. We are right now on the actual website, our research tool is up because we have a version that speaks multiple languages and is video assisted, hoping to increase accessibility. So that'll go back to the standard patient tool when available. But my hope is that in the community pharmacies, the pharmacists can actually feel comfortable doing the questionnaire, the healthcare provider tool, or at the very least encouraging patients to do the patient tool.
How do you educate patients or parents on the occurrence of the delayed mild rash, and how do you manage it while still completing their antibiotic therapy?
So typically what I would say is exactly what I said in the presentation. I would say there is about 5% of people who get a delayed rash. Usually it will be in the next few hours. We encourage you to take a picture. Most of the time it's nothing severe. We do ask them to send it to us by email or to follow up, just so we know what's going on. But then I do follow up and say, according to our current guidelines, international ones, that delayed recurrent mild reactions are not a contraindication to therapy. And I also tell them that if it's been more than 24 hours, the drug has essentially been left in negligible amounts in the system. So anything that happens beyond that is unrelated.
And here's what I tell our pregnant patients as a part of our group counseling. So I tell them that there's about, in our rates are, it's about 2% of pregnant people will have a delayed rash. I tell them it's going to appear 3 to 5 days afterwards. It will inevitably happen at 3 o'clock in the morning when it's annoying and keeps you up at night. And Claritin and Reactin are completely safe in pregnancy, and that they should call the clinic back, and we will chat with them about their reaction, and one of our allergists will call them back. And the reason that we do that, and I explain this to them, is, as Tiffany pointed out, it's not a contraindication to therapy. It's annoying. And when you're 60 years old and you have a UTI, you may choose an alternative so you don't get that annoying rash. But if you're in a car crash and a beta lactam is going to save your life, you will pick the life-saving antimicrobial. And for us on labor and delivery, that's really important to know that reaction. And we actually document that in the patient chart and in the PharmaNet, which is their drug database, and in our electronic medical record. And then we tell them to have that information so that they can make an informed decision in their healthcare later.
Chelsea, how many patients have you had come back with a delayed rash?
Yeah, it's about 2%. Yeah. And they call the clinic, and then we call them, and we'll sometimes give them a Betaderm cream and tell them to take React and Claritin. We'll reassure them, but it's about 2% for us.
Thank you. Are all provinces practicing delabeling? Is this simply something that's asked of a primary care physician?
This is a very good question. I would say that I have been approached by teams from most provinces. Not that I have any jurisdiction over any of them, except for some in British Columbia. We are very mindful that we're trying not to create extra work burden for family physicians. My hope is to educate so that it makes your lives easier, so that you have tools that are readily accessible, they're fast, they're efficient, they're evidence-based, they're validated. But we are always here as allergists to answer questions, and we acknowledge that there are patients who really do have drug allergies. So we are very happy to see any of these patients. We're just trying to speed the process along so that patients who live far away or don't have access to specialized care can get this assessed in a rapid manner.
And along those lines with Tiffany's point around timing, on average, it's a couple of years to see an allergist in the community to get this testing done. People might have had 2 or 3 babies by then. So those timelines really don't work often in an obstetrical setting where there's a direct benefit. So sometimes having directed services for pregnant people with the deadlines of a delivery are helpful.
Okay. Somewhat related, accepting the limitations of skin testing, is it reasonable to have access to the same in a primary care setting? And has the program concept been reviewed by CMPA?
I'm not totally sure if I'm reading the question correctly, but if the question is, can you do skin testing in a primary care setting? I mean, the question is yes, but I would say the number of times I've done skin testing is so small, it's probably not worth your time. The reagents are expensive, they're not accurate. So I've only done it less than a handful of times in the last 10 years that I've been doing this. If the question is whether it's reasonable to assess risk and delabel allergies with a drug challenge in the community setting, we have a wealth of data indicating that all of these validated tools are reliable. And remember, these are the patients who are not allergic. So anyone you're concerned about, anyone who's higher risk can be sent to us or a specialized center for further assessment. And because the risk is low, this is standard of care and would fit well within the scope of all of our medical practices.
Thank you. In the interest of time, I think we're going to have to wrap up here. We just have about a minute left. I apologize if we couldn't get to everyone's questions. There were a lot coming in through the Q&A, so we appreciate the interest in the topic. Just as we close out, I had a couple announcements to make. Harper, I think you want to share the slides again? Thank you. So I've just been asked to remind everyone of the next CanAMS webinar, which is scheduled for June. The specific date is still to be announced, so check back to the AMR Aware Canada website for more. But the topic will be Small But Mighty, Promoting AMS Activities in Rural Communities. And you can join us to discuss efforts to promote antimicrobial stewardship interventions in rural locations across Canada with speaker Catherine Neal, who's a pharmacist in Saskatchewan. The other reminder is that today's recording, a recording of today's session will be posted on the AMR Aware Canada website and on YouTube. So if you'd like to send it to a colleague, please feel free to do so. And we do ask you to take a few moments to complete a evaluation of today's session, which you can access via the QR code, or I think we might have a link being posted as well. So with that, I'd like to say one more big thanks to Dr. Wong, Dr. Elwood, and me, and to all of you for being here today. It was a great presentation, a great discussion, and we hope it leaves you with lots to think about. So thanks everyone, and have a great rest of your day.